welcome to the June 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
Well, here we are in June already, Alice, and that means ADA scientific sessions will be taking place later this month from June the 20th to the 23rd in the Windy City, Chicago, Illinois.
And looking at the program, it seems that the Scientific Planning Committee, with Dr. Mark Atkinson as chair, has done a stellar job of assembling a high-quality 4-day conference with something for everyone. Are there any sessions that you are particularly looking forward to, Mike?
Well, I have 3 trainees presenting abstracts at this year's meeting, and so I'm super proud of them and excited for their sessions. Mark did involve me in planning one session together with Dr. Melina Belland from University of Minnesota in Minneapolis and Dr. Holger Russ from the University of Florida in Gainesville. And this is a session that will be jointly sponsored by the International Pancreas and Islet Transplant Association and has an outstanding lineup of international experts who will be addressing different strategies of immune evasion for transplanted islets that hope to obviate the need for immunosuppression, and at least in one case have already entered a first-in-human clinical trial. So this is Monday morning at 8 a.m. for those who might be interested. And then another for me will be the Banting Medal, which is always a great session, but this year in particular will be given by Dr. Stephen Kahn, this year's Banting Medal recipient. And for our listeners, as Alice knows well, Stephen is not only our fearless editor-in-chief at Diabetes Care, but also a real role model of an exceptional clinical investigator that I and countless others have striven to emulate over the years. And Stephen really makes this possible with his generous mentorship of so many colleagues. And Stephen's fundamental discoveries in the relationship between insulin secretion and insulin sensitivity during the progression of glucose intolerance toward type 2 diabetes have made an enormous impact in the field. And I've certainly applied this foundational knowledge in my own research of islet function involving other populations with diabetes. So I'm really happy for Stephen and want to call out terrific interviews given by both Mark and Stephen about the upcoming scientific sessions that you can find in the May podcast episode of our counterpart, Diabetes Bio, that covers the content of our sister journal, Diabetes. And before I let Alice say anything, and she's going to be really sorry she gave me this much of a chance to speak, I am really thrilled, Alice, with you being selected for this year's Outstanding Physician Clinician in Diabetes Award. Working with you over these past 2.5 years, and I know our listeners can all attest, this is a most well-deserved recognition of your contributions to clinical practice, medical education, and the dissemination of new knowledge and approaches in diabetes care and management that have had such wide-reaching impacts. Congratulations, Alice.
Oh, thank you, Mike. Thank you for your kind words. And I'm certainly very humbled to receive this award. And I had actually joked with the people who nominated me that I would get this award when pigs fly. So apparently pigs fly. So I was quite shocked to get the call, and a huge thank you to everyone who has supported this. But I completely agree with you, Mike, with everything you've said about Stephen Kahn, an accomplished and impactful researcher, and also a passionate mentor and a kind soul. And I think he was the one who picked up the phone and called each of us to ask if we would be interested in being part of this podcast series. And I certainly appreciate everything that Stephen has done and allowed you and I to get to meet and work together, which has been wonderful.
Absolutely.
So congratulations to Stephen for his very well-deserved Banting Medal. And along the lines of award lectures, I'm also very much looking forward to the Kelly West Award for Outstanding Achievement in Epidemiology lecture by the very inspirational Professor Juliana Chan from the Chinese University of Hong Kong. And that will take place on Sunday at 3:15. She'll be discussing her pioneering work on the Hong Kong Diabetes Register and how it has redefined diabetes care. And of course, there are first-in-world readouts of important trials, and that happens at every ADA. This year, we can look forward to results from the Pathway trial, which is a randomized trial of a pragmatic approach to weight management in primary care. There's also Redefine 1 and 2, which are trials of Glycemia in obesity with and without type 2 diabetes. There's the Believe study, which is a phase 2 study of the combination of bimagrumab, which is a monoclonal antibody that blocks muscle activin 2 receptors developed to treat sarcopenia, in combination with semaglutide. So I think that'll be very exciting. There's also the Maritide phase 2 data of a monthly dual GLP-1 agonist and GIP antagonist. The Adjust T1D study of adjunct semaglutide in type 1 diabetes. And last but not least, a very cool study, and I'm looking forward to the final results, the Catalyst trial of mifepristone in addressing hypercortisolism in difficult to control type 2 diabetes. So tons and tons to look forward to. And as I was going through the program, it was like I could clone myself and be in 3 different rooms at the same time. That would be ideal. I do want to do a shameless plug, though. So we are again going to do another live podcast recording at scientific sessions like we did last year. This will take place on Monday at 12:30 p.m. And this will be Mike, myself, along with the other hosts of the ADA podcasts, Diabetes Bio, Diabetes Core Update, and Diabetes Day by Day.
So we both hope to see you all in Chicago at the 85th ADA Scientific Sessions.
Agreed. And now let's dive into this month's diabetes care. One of the feature articles from the June 2025 issue of Diabetes Care is an original article entitled Weight Gain was Associated with Worsening Glycemia and Cardiovascular and Kidney Outcomes in Type 2 Diabetes Patients Independent of Diabetes Medication in the GRADE Randomized Controlled Trial by Dr. Deborah Wexler and colleagues. I'm joined today by Dr. Deborah Wexler, endocrinologist, chief of the Massachusetts General Hospital Diabetes Unit, and associate professor of medicine at Harvard Medical School, and a past guest on Diabetes Care on Air for our April 2024 episode. Welcome back, Deborah, and thank you so much for agreeing to be part of this podcast again, and congratulations to you and your collaborators.
Well, thank you for having me again. Thanks for featuring this paper. I'm a big fan of the pod, as they say in the biz, so it's great to be here with you.
Woohoo! You even got the lingo down. Well done. In that April 2024 episode that I just mentioned, we had an in-depth conversation with Doctors David Nathan, Jennifer Green, and Matt Riddle about GRADE and some of the new insights that were published in that special collection. And I encourage our listeners to go back and take a listen if they missed it. Before we dive into this new analysis, though, Deborah, can you give the audience a high-level 30-second reminder of what was the GRADE study and its key primary findings?
Yes, happy to. Thank you. GRADE was a long-term comparative effectiveness study that randomly assigned a little over 5,000 people with type 2 diabetes to a sulfonylurea glimepiride, a DPP-4 inhibitor, sitagliptin, a GLP-1 receptor agonist, liraglutide, and basal insulin glargine, and followed them for an average of 5 years to assess all sorts of outcomes. But the primary outcome was time to A1C greater than 7, and then time to A1C greater than 7.5. So it was primarily a glycemic outcomes trial, although we assessed numerous other types of outcomes. And what we found is that actually over time, the majority of people hit that outcome within about 2.5 years, regardless of treatment. But the injectables, insulin and liraglutide, were more effective than sitagliptin and glimepiride at maintaining glycemia over time.
Excellent. Thank you for that great summary. For this month, you have brought us another interesting analysis from GRADE looking at weight gain and its effects on glycemia and outcomes. What were the questions asked and why were they important to ask?
Well, I think anyone who takes care of people with diabetes is concerned about weight loss, ideally, and weight gain on treatment. And here in GRADE, we had an opportunity to assess longitudinal weight on these 4 common classes of glucose-lowering medication. So we wanted to assess the detailed weight outcomes over time. And importantly, we wanted to figure out whether weight gain undermined the efficacy of therapy over time.
Important questions to answer indeed. So let's start off with weight change then. In this analysis, you provide a more detailed look at this. What were the key findings there?
So actually, we already reported the top line weight results of GRADE, which is that on average, everybody lost weight in GRADE. But here we took a closer look at what happened sort of along the way. And what we found was that at 1 year, people in the glargine and glimepiride groups gained weight, and the people in the sitagliptin and liraglutide groups on average lost weight. But that after 1 year, between year 1 and year 5, all of the groups lost weight after time. In addition, we found that the group that actually gained the most weight was the sulfonylurea group, glimepiride, gaining about, I think, around 0.9 kilograms over time. The glargine group gained about half of that in the first year. And then, of course, the liraglutide group lost about 3.5 kilograms, and the sitagliptin group lost about 1 kilogram by year 1. But then over time, liraglutide sort of stabilized, and everyone else lost weight over time.
Now, how about the association between weight gain and the glycemic outcome of HbA1c 7.5% or greater? What was found?
So this is a sort of a finer point. So one of the interesting things about GRADE is that we randomly assigned people to the second glucose-lowering medication added to metformin and observed them until the A1C hit 7 confirmed, and continued them on the randomly assigned combination therapy until the A1C hit 7.5. So for this analysis, we looked at all of the time that people were treated until the A1C was confirmed to be 7.5. And at that point in time, like really 98% of people were on the assigned therapy. So this is really the effect on treatment. And we looked to see if you joined GRADE and gained weight over the first 6 to 12 months of the trial, what happened to outcomes after that period of time. So it's important to mention that what I'm about to describe now is not a randomized analysis. It's sort of the observational analysis of what happened in each randomized treatment group over time. And what we found is that for every kilogram of weight gained in the first 6 months of GRADE, on average, there's a 5% risk of hitting that outcome of A1C of 7.5, which is to say that if you gained weight on treatment, regardless of which treatment, you're likelier to have a deterioration in your A1C. And of course, this makes sense. This is what we know to be true about diabetes. There were slight differences between treatment groups, but I think there's 2 take-home messages from that. One is that 1 kilogram of weight gain was only associated with a 5% risk of hitting an A1C of 7.5, but the model would suggest that for every kilogram of weight gain, there's a 5% risk. So if you were, for example, to be one of the people who gained 5 kilograms, 10 kilograms, then your risk of deterioration is obviously much higher. It's going to be multiplied by that 5%. So for example, if you were to have a 5 kilogram weight gain in the first 6 months, you might have a 25% risk. For example, the model would predict of hitting an A1C of 7.5 thereafter.
Which is fairly substantial.
It's fairly substantial. And I think on the one hand, that puts something that we all understand to be true and puts some numbers around it. So we know when our patients are having weight gain, they're at risk. This can sort of tell you what that risk is likely to be. The practical implication of that, I should back up a step and say that on average, people lost weight in GRADE, but there was a lot of variability. Some people gained weight, some people lost weight. You know, if you have a patient who's gaining weight on a medication that you've prescribed, probably that's not the best medication for them, particularly if they're rapidly gaining weight. And of course, we've all seen those patients. And so that's just an important take-home message from this analysis.
Very useful indeed. And then you also looked not just at the glycemic outcome of A1C 7.5% or greater, but you also looked at the cardiovascular, renal, and neuropathy outcomes. So what did you find there?
Yes. So we looked at, in GRADE, a very wide composite cardiovascular outcome and found that for every 1 kilogram of weight gain in the first 6 months of the trial, there was a 3% risk of subsequent cardiovascular outcomes. So again, a modest amount of weight gain wouldn't be expected to increase your cardiovascular risk that much. But if you're one of these people who gain 5, 10 kilograms right up front, your risk of cardiovascular outcomes would be multiplied. And similarly, for kidney outcomes, a kilogram weight gain in the first year was associated with subsequent progression of chronic kidney disease over time, about 3% per kilogram.
Weight gain is definitely something that we always measure and watch for in clinic. And you're right, this now puts numbers around it, which is quite powerful. There was something I wanted to talk to you about, though. There was one thing that surprised me when I was reading your paper, and in fact, you've mentioned it a couple of times in this interview already, and that is that all the groups lost weight over the 5 years. The initial weight change that was found in GRADE, made sense to me. There was weight loss with liraglutide and a little bit with sitagliptin, and there was weight gain with glimepiride and glargine. But why weight loss over time? Because I got to say, in the clinic, that's not really what I'm seeing.
Well, on average, there was weight loss over time. And what I would say is that I think we all have a little bit of recall bias. The effects of glucose medications on weight are often short term, and they happen in the first year, and that's what we saw. When you actually look at other long-term trials like UKPDS, control arms of the Accord, the control arms of Look Ahead, those patients, when followed over time, actually all tended to have weight loss. And that may be because they're aging. It may be because they all have diabetes and they're trying to lose weight. It may be because they're people who joined trials, as people who joined GRADE were motivated and joined a trial, and therefore maybe are more successful with their weight loss attempts over time. So I think there's a lot of factors. We do even see, though, clinical populations followed over time with type 2 diabetes will tend to have gradual weight loss over time. And I think that is what we saw in GRADE. I guess the take-home message would be if people have dramatic changes in weight with the medication, and we did see that in GRADE, let me come back to that in a minute, we have a problem. But a modest change in weight, maybe for the short term, and may not have a dramatic impact on the clinical outcomes over time. One of the things that we did in GRADE is when people had 10% or more weight gain, we actually stopped the assigned medication. We sort of knew enough to say, all right, this is not a good medicine for this patient. And so we might have mitigated the effects of the more extreme weight gain that you might see in a patient, for example, who you start on high dose insulin and continue on high dose insulin and has a lot of weight gain over time. So we might have limited that contribution to some degree in GRADE as well.
Now, you've given us some take-home messages already, but how do we interpret these findings in the context of the treatments that we're now using? When GRADE was started, those were the 4 therapies that were chosen. But living in 2025 now, we've got therapies that have profound weight effects in terms of weight loss compared to the ones used in GRADE. So what do we do with this information?
So weight loss is a key determinant of effective diabetes management, and we're now fortunate to have these highly potent GLP-1 receptor agonists that promote substantial weight gain and really seem to modify the trajectory of diabetes. I would say the results of GRADE are still quite relevant because we as diabetes care providers have patients who either can't tolerate those medications or even on those medications may have continued hyperglycemia. And I think in all of our focus on weight, it's important to remember the results of every study that we've shown where the A1C really is a determinant of microvascular and even over the long-term macrovascular outcomes. So we still do need to manage hyperglycemia. We need to manage it in the patients who are failing these meds, who are not tolerating these meds. And for those people, it's important to think about all the other therapies that are available, which we did study in GRADE, and how to use those medications most effectively.
So what I've heard from you is that glucose management still matters. Weight also matters. And this analysis has provided some numbers to understand the association between weight gain on treatment, as well as glycemic outcomes and complication outcomes. So thank you very much, Dr. Deborah Wexler, for sharing your expertise with us today and helping us put this in the context of 2025. Congratulations again to you and your colleagues for another insightful analysis from GRADE, and thank you for joining this podcast. And I encourage our listeners to read the full article in the June issue of Diabetes Care.
In the June 2025 issue of Diabetes Care is a feature article that asks the question, is the current lifestyle modification approach to diabetes prevention in the United States a success? Here with us to answer this question, and for those of you who may already know the answer, to help us better understand why, is the article's first author, Dr. Justin Echouffo-Tcheugui. Dr. Echouffo-Tcheugui is an associate professor of medicine in the Division of Endocrinology at Johns Hopkins School of Medicine in Baltimore, Maryland. Justin, I'm delighted you could be here.
Mike, thank you for having me. It's really an honor to be a guest on the Diabetes Care podcast.
Well, congratulations to you, Justin, and your co-authors on this feature article. Let's start with the elephant in the room. Is the current lifestyle modification approach to diabetes prevention in the United States a success? And on what evidence are you basing your answer?
Thank you for this question. The evidence that we presented in the paper was compiled from various sources, we sort of extracted evidence mainly from non-randomized studies. And these sort of observational studies included surveys. For example, we used data from the NHANES to look at the trends in the prevalence of prediabetes among adults and children across the US. And that data from NHANES showed stagnant figures in adult and increasing rates of prediabetes in children and adolescents. We also used the behavioral risk factor surveillance survey, which provided us with data on the burden of undiagnosed diabetes. So the extent to which prediabetes is not diagnosed in the community, sort of implying that there's a low detection rate. The behavioral risk factors survey data also gives us information about the low referral rate for lifestyle intervention, as well as the low uptake of any lifestyle intervention or counseling provided by the healthcare providers to those who were referred for a program. And the other type of studies that we use are cohort studies. An example is the SURGE study, which is the largest study of diabetes in the youth, which provided data on the incidence of diabetes in adolescents. Another type of evidence came from repeated evaluations of the CDC National Diabetes Prevention Program at different time points. The CDC National Diabetes Prevention Program started in 2012, and there have been multiple publications, mainly descriptive studies, which provided data on the status of enrollment to the program, the retention rate of those who were enrolled in the program, as well as the extent to which people enrolled in the program lost weight over time, as well as the A1C at the beginning of the program and then subsequently. We also canvass the website of organizational agency that provide diabetes prevention services, namely the Center for Disease Control Registry of the sort of accredited suppliers, as well as the Center for Medicare and Medicaid Services, which they provided information not just on the suppliers, but also on the payers and the extent to which there's coverage of the lifestyle intervention offered by these organizations. And lastly, we also use evidence from economic studies by various groups across the country on the cost associated with delivering lifestyle intervention for diabetes prevention. So, say multiple sources from which we sort of derive the evidence to assess to what extent the National Diabetes Prevention Program in the US has been successful or not.
And your bottom line answer?
The bottom line answer is that so far we're not doing very well, because after more than 10 years of implementation of the CDC National Diabetes Prevention Program, the results are not looking very good. It's not very encouraging. We're still lagging behind because a limited number of people have been sort of enrolled in those programs. Like only about 1 million of the 97 millions of people with prediabetes in the country are in the CDC program. That's a very low number. And then of those who are in the program, less than 1/3 of those people complete the program, which is a 1-year program. And then, the data on the extent of weight loss also indicates that not many people are losing weight. And then when we look at parameters like A1C, A1C is evaluated in that program over a 1-year period. It's not also very encouraging.
And your article explains this large prevalence of prediabetes. So 1 in 3 American adults. And also, as you mentioned, the proportion among adolescents, it has been increasing to nearly the same figure and driving this increase in incidence of type 2 diabetes. So this is such a huge problem, but getting individuals enrolled in preventive services, you discuss how there's an extremely limited supply of diabetes prevention services available nationally. And so why has the supply of diabetes prevention services and programs accredited by CMS and the CDC not risen to meet the potential for demand of those services?
That's a sort of challenging question, but I think the obstacles lies at 2 levels, right? They are structural obstacle. I will call them the macro level obstacle as we sort of designated them in the paper. And then there are micro level or individual level barriers. So if we look at the supply across the country, as you mentioned, there's a limited number of suppliers. For example, if we look at the Medicare suppliers, there's only 1.5 sites for the Medicare program per 100,000 Medicare beneficiaries. So I don't think even in the CMS, that is sort of the largest payer, has managed to provide that program to enough Americans. There's also a geographical mismatch between the demand and the supply. So in other words, the places where we have the highest number of people with prediabetes have the lowest number of supply. For example, as of 2022, in Connecticut, New Mexico, and Washington, D.C., there was only one site for more than 600,000 Medicare beneficiary, which is equivalent to approximately 200,000 Medicare beneficiary per site, which, we're not really meeting up with the demand. The other major problem is the coverage, the sort of the financial coverage of the program, right? So who is paying for the program? The largest payer is the CMS, and we have a limited number of commercial payers that cover for the program. So it's a financial problem. And even in terms of the coverage, for example, when we look at the CMS, there are limitations to the coverage, right? So the reimbursement for Medicare is based on a pay for performance system or scheme, whereby, the reimbursement is conditional upon reaching certain targets. The targets at 6 months in terms of weight loss, and their targets at 12 months. And the result of that is that there is under reimbursement by Medicare, because the organizations that deliver the lifestyle program, they are forced to pay for the program regardless of the performance. And it may be that in the end, the costs are not reimbursed. So it's going to be a loss. So the question is that a sustainable sort of payment scheme? The question is in there. So it's not been sort of really addressed. The other problem is that the coverage is limited to certain population. I mean, you can imagine that for Medicare, it covers only people who are 65 and above. And also the duration of the coverage is a problem, right? So, for example, the Medicare beneficiary are only eligible once upon their lifetime, whereas diabetes prevention is a lifelong issue, and the coverage is only for about a year. So if people fail the first year, they will not be covered if they try it again. So that limits sort of the possibility of really achieving diabetes prevention. So those were sort of the macro level. So funding, financing the lifestyle programs. The micro level barriers is also numerous. So for example, if we go into sort of the health system like the Hopkins health system, or maybe the partner healthcare system in Boston, we look at what the providers are doing, the rate of referral to the programs is very limited, right? Even before that, to the extent to which the prediabetes is detected is low. There's about 30% of people with prediabetes across the country that are not even diagnosed. It means that people are not even detecting diabetes in clinical practice. Once they detect prediabetes, only about 50% of those who had received some sort of biological testing like A1C are offered lifestyle advice, and less than 10% of those people are actually referred to an accredited program. So even the programs that are in existence are underused by the practitioners. And it seems that a lot of providers are not aware of those accredited programs. So because those are programs that receive an accreditation by the CDC because they can deliver a sort of DPP-like intervention, which has been shown. It's modeled after the DPP model. I mean, it's modeled after the DPP intervention, which was proven in the clinical trial to be effective in preventing diabetes. As I mentioned previously, the enrollment rate is very limited. Even if when people are referred to those programs, there will be the issue of coverage, and then, not everybody ends up being sort of enrolled. And those who end up in the program do not stay until the end. There's less than 1/3 of those who start the program end up, finishing it. And so they may end up not really deriving a benefit from it. And there are other sort of barriers. So the mode of delivery, because it requires a certain amount of time commitment, So especially if the attendance is going to be in person. So they are virtual options, which presumably have the same level of effectiveness in terms of leading to weight loss. But it also requires time commitment because they are at least 22 sessions. So somebody who is enrolling in the program has to commit to, complete it. And that requires a certain degree of motivation. And as we know, lifestyle intervention are inherently difficult and people have to be motivated. Yeah. So those are sort of in a nutshell, some of the sort of micro level barrier that we highlighted in the paper.
Yeah, so time and money, it seems like those two factors, become so important and create so many challenges for individuals to overcome. And so, Justin, for those with prediabetes who have managed to be identified, referred, and have been able to access and enroll in a national diabetes prevention program, what are the real world outcomes in how these individuals do?
I would say that, the evaluation of the national program has sort of focused on mostly on the process of care measures. So the reason I'm mentioning process of care measure because they are also sort of the hard outcomes, and I'm going to mention it a little bit later. So the evaluations have sort of looked at the uptake, they've looked at the retention rate in the program and the extent to which those people lose weight. It's obvious that when people stay longer, they adhere to the program, they lose more weight. But as I said, a lot of people do not adhere to the program till the end. And so they don't do well in terms of losing weight because the idea is to lose at least 5% of the weight, the starting weight. And then the other outcomes that has been examined is A1C. But the problem is that A1C has been examined over only a 1 year period or less in those programs. And a 1 year period to evaluate, the efficacy or the effectiveness of the intervention is a little bit short because over 1 year, even outside of the intervention, there are not a lot of people who convert from prediabetes to diabetes. The other sort of outcome will be the regression from prediabetes to normal glucose tolerance. And so 1 year is probably not the appropriate time frame to really evaluate the outcomes of the program. The other challenge is we don't have data on the sustainability of the program beyond 1 year. What is the diabetes incidence over like a 3 year period? And I'm mentioning 3 year because that's the period that was initially over which, the diabetes incidence was initially assessed in DPP. It's true that over time in DPP, they've shown that even after the active intervention, the benefit sort of persisted over time. So we don't have that long-term view for the National Diabetes Prevention Program. And importantly, we don't have data comparing those engaged in the program and a population of people not engaged in the program, because sort of a lot of those evaluation was within the program evaluation and let's say, of those people. So we probably need that kind of data to say that, this program is really effective because those who enroll, irrespective of how long they stay in the program, ultimately, maybe in sort of the medium or the long term, have less diabetes than those who were never in the program. The other major gap relates to the economic aspects. So we have an idea of the cost, and a lot of studies that have been published are studies on how much does it cost to deliver the intervention, but we don't know if it's effective, right? If it's cost effective, because we need effectiveness data to be able to sort of have some cost effectiveness ratio. So we're lacking that data on sort of the cost effectiveness. I mean, from different perspective, we can conduct that evaluation from different perspective. That data is not there. So just to summarize everything that I just said, in terms of outcomes, those who enroll stay long enough in the program will lose weight. The A1C will go down, but the time frame over which we've sort of observed that is short, is 1 year. Those who do not stay in the program are not going to have good outcomes, but we need data over a longer time period, and we also need data on the cost effectiveness of the intervention.
And Justin, another limitation that you describe in your article regarding the intervention is that this is largely a one-size-fits-all lifestyle intervention approach for preventing progression from prediabetes to type 2 diabetes. And yet there's been lots of this discussion about heterogeneity of type 2 diabetes. And so what evidence is there for varying the approach to prevention by, say, subtype of pre-diabetes?
Yeah, tough question. So I think the evidence is mostly indirect. So we don't have direct evidence because we don't have studies in which we've sort of varied approach, and then we see that, depending on the phenotype, we have, different response. But using data from, randomized clinical trial and observational study, we can sort of infer that perhaps a sort of differential approach will lead to possibly better results. And the beginning of the heterogeneity, is in the definition of prediabetes itself, because if you remember, we have at least 5 different phenotypes of prediabetes. We sort of have this massive heterogeneity with IFG, IGT, and A1C based, definition of prediabetes, depending on, on the country. In some places, you use different cut points. But inherently, I don't think IFG and IGT fundamentally, from a biological perspective, are the same entity. So it's heterogeneous in nature. But there's also data from clinical trials suggesting that IFG, for example, does not respond well to the sort of lifestyle intervention. And it may not also respond well to metformin. So especially isolated IFG. So there are some clinical trials, if my recollection is correct, from Japan and also from India, sort of suggesting that, the response to lifestyle intervention is not the same as with IGT. It seems that IGT responds better. And I have to point out that, DPP enroll people primarily with IGT. Some of those people had IFGs, but the criteria for enrollment was based on IGT. The same with all the other clinical trials that were conducted outside the US, sort of the Finnish prevention study, I think the Indian prevention study, and as well as sort of the DACing prevention study. So presumably, there will be differential response. So it may be that we've too easily extrapolated what we see with IFG to other prediabetes phenotypes. And this is very important because in clinical practice, our diagnosis is mostly based on A1C. So the phenotypes that we describe is an A1C based phenotype. And a lot of intervention studies did not recruit people on the basis of their A1C. It's true that there have been sort of subsequent analysis, even in DPP, to try and show that even an A1C based definition may lend itself to that kind of intervention. But primarily, the recruitment in the proof of concept clinical trial wasn't based on the A1C phenotype. The other indirect evidence comes from studies that have used sort of the omics techniques, metabolomics, proteomics, transcriptomics, and looked at those known phenotype based on A1C, fasting glucose or 2-hour glucose tolerance tests, but also people have tried to cluster sort of people based on sort of those biological markers, those peripheral blood-based biomarkers. And there are differences, right? So the population is not homogeneous. There's a certain degree of heterogeneity, and based on the markers in the clusters, so we can assume that the response to therapy, including lifestyle intervention and the sort of drug therapy, may not be the same across those individuals. So that's where sort of the idea of heterogeneity and possibly a differential response to intervention comes from. But there's still a long way to sort of operationalize that.
Yeah, a long way indeed, Justin. And 2 years ago on this podcast, we covered the National Clinical Care Commission report to Congress on diabetes treatment and prevention. And regarding prevention, the report called on Congress to address the same broader societal issues your article raises regarding our food system and built environment, as well as facilitating FDA approval of medications such as metformin, shown in the diabetes prevention trial to be efficacious in preventing progression of type 2 diabetes. And so to help broaden insurance coverage and access to these treatments? And are we making any progress on these broader fronts?
Yeah, another tough question, especially as this sort of relates to issues outside sort of the clinical care settings. Those are issues that sort of have to do or involve governmental agency and multiple agencies. So regarding the progress, I think as far as I know, since the publication of the report in 2023, I don't think there's been a lot of movement on that front. So I'm not aware of any sort of major policy shift or any new policy that was adopted that sort of will fundamentally change the situation of diabetes prevention in the country, right? I think a lot still needs to be done. And so to answer the question, what else can be done? I would just say that if, at least, just 1/3 of what was sort of mentioned in that report or was recommended in that report was sort of implemented, I think it would be fantastic. So I think it would go a long way to help the situation of diabetes prevention. So in a nutshell, not a lot from that, as far as I know, from that report has been sort of implemented. And so it still needs to be implemented. And that report addressed some of the core issues that we sort of highlighted in the paper.
So one step at a time, but a process that we've undoubtedly need to start making those steps towards, with each step having a potential of making enormous impact given the scope of the problem. And with that, Justin, do you have any final takeaway messages for our listeners?
My takeaway message is that, there's been a lot of progress in the field of prediabetes, but overall, a lot remains to be done. I think we need to think about diabetes prevention as, a whole, not just a clinical issue, because it requires concerted and continuous efforts at different level in the clinic, because it requires the commitment of providers and patients. But if, outside of the clinic in the community, we need to sort of make specific efforts, and some of the things that were mentioned in the report that we just discussed are very important to achieve that in the community. And it sort of requires the involvement of the society in general, because all the sort of the financial issues that we discussed, they go beyond what a sort of clinician can do. It requires some sort of fundamental societal changes. And all of that makes it sort of challenging. So,
Well, Dr. Echouffo-Tcheugui, thank you so much for sharing your expertise with us today. I really appreciate all I have learned from your review and our discussion about the current limitations to diabetes prevention in America. And I really hope that greater awareness of this problem, as well as of steps that we can start taking to really help address this problem and lead to solutions. I encourage our listeners to access the full article in the June issue of Diabetes Care. Let's move on now to our rapid exchange segment, where Alice and I chat about some of the articles we found particularly interesting this month. Alice, what's your first pick?
This was a particularly tough month for me to narrow things down to just 3 picks. So I'm going to try my best, just admitting it up front. My first topic is about SGLT2 inhibitors. So Dr. Priya Bapat and colleagues, with the senior author of Dr. Bruce Perkins from the University of Toronto, which is where I come from. So hey, Priya, hey, Bruce, looked at whether routine capillary blood ketone testing can predict future DKA in type 1 diabetes in those taking SGLT inhibitors. They examined previously collected weekly fasted ketone levels from empagliflozin-assigned participants in a T1D trial and correlated those with subsequent adjudicated DKA or severe ketosis. The weekly ketone levels were subdivided into 28-day periods. They found that maximum ketone levels were higher in the 28-day period preceding an event compared to those without an event. The max ketone level of 0.8 millimoles per liter or higher had a sensitivity of 66%, specificity of 79.6%, and diagnostic odds ratio of 7.6. This is suggestive that routine surveillance of capillary ketone levels in type 1 diabetes using SGLT inhibitors with a threshold of 0.8 millimoles per liter may be a DKA risk mitigation strategy. This will be interesting as continuous ketone monitoring becomes a reality in the not too distant future.
I totally agree, Alice. And these are really important data because while still requiring prospective validation for our patients with type 1 diabetes treated with SGLT2 inhibitors for renal protection or heart failure indications, having a ketone monitoring threshold for when to recommend holding therapy in outpatient practice, even if it's with a capillary blood ketone meter available currently, can have an immediate impact. For my first pick, I'm going to stick to the theme of SGLT2 inhibitors and call attention to a randomized clinical trial by Dr. Fabio Grinspan-Pita from the University of Sao Paulo in Brazil and colleagues that evaluated the SGLT2 inhibitor empagliflozin in individuals with type 2 diabetes undergoing on-pump coronary artery bypass grafting or CABG. 145 participants scheduled for elective CABG were randomized 1-to-1 to receive either 3 months of pre-surgery empagliflozin therapy or standard of care, and those assigned to empagliflozin discontinued therapy 72 hours before surgery. Those treated with empagliflozin before on-pump CABG almost halved their risk for experiencing postoperative acute kidney injury that was assessed at 7 days postoperatively, with no observed euglycemic diabetic ketoacidosis or increase in urinary tract infections observed in the treatment group. To me, these results demonstrate a strategy for potentially expanding the benefits of SGLT2 inhibitor therapy without increasing well-known risks of their continued use in the NPO setting.
And I think that this study, along with others that we have also discussed over the course of this podcast series, is really painting a picture that our previous reflexive discontinuation of all SGLT2 inhibitors well before anybody goes to hospital, or certainly when they show up in hospital, probably should not be a reflex anymore. And all of these data suggesting that it may actually protect against AKI, which was not what we thought at the beginning, right? So this is one of the beautiful things about medicine is the constant evolution of new knowledge and sort of changing the way we do things. So I look forward to hospital protocols starting to adapt and change. And I think that often will take time, but these data certainly support that. My second pick happens to also come from the University of Toronto. And yes, I am totally biased and I agree. As you know, the International Diabetes Federation recently endorsed a 1-hour oral glucose tolerance test as an option to the conventional 2-hour OGTT to diagnose what they called intermediate hyperglycemia, defined as a 1 hour of greater than 8.6 and greater than 11.6 being diabetes. This would be millimoles per liter. Dr. Ravi Ranakaran and colleagues, hey Ravi, sought to compare the 1 hour and 2 hour OGTT glucose measurements at 3 months postpartum as predictors of prediabetes or diabetes over the first 5 years postpartum. 369 women with normal glycemia or GDM underwent 75-gram OGTTs at 3 months, 1 year, 3 years, and 5 years postpartum. At the 3-month OGTT, the 1 hour glucose level identified all but 10 of the 70 women with dysglycemia based on the 2 hour value, while diagnosing an additional 96 women with dysglycemia. The top 5 predictors, from highest to lowest, of dysglycemia at 5 years were: number 1, 1 hour OGTT glucose at 3 months, followed by 2 hour OGTT glucose at 3 months, then non-white ethnicity, then fasting glucose at 3 months, then BMI. So therefore, the 1 hour OGTT may offer a strategy to assess for postpartum dysglycemia in women with hyperglycemia in pregnancy, knowing full well that actually getting that postpartum test is so very difficult. So anything we can do to simplify things, I think, would be very welcomed.
Well, I'm so glad you picked this one, Alice. And Another population, individuals with pancreatic insufficient cystic fibrosis, our group has shown that the 1 hour oral glucose tolerance test glucose at the same threshold of greater than or equal to 8.6 millimole per liter or 155 milligrams per deciliter already identifies those with a significantly reduced beta cell secretory capacity, manifest with impaired early phase insulin secretion. So it reasons to me that during pregnancy, women whose beta cell mass is inadequate to increase insulin secretion sufficiently to meet the demands of gestation would be those likely to demonstrate an elevation in 1 hour OGTT glucose postpartum. And so perhaps this 1 hour OGTT glucose measurement may be particularly sensitive for predicting future progression of dysglycemia in populations where beta cell dysfunction is the driving defect. My next pick sticks with the theme of diagnostic assessment. Dr. Gila Ginsburg from the Medical College of Wisconsin in Milwaukee and colleagues report on an analysis of 234 youth with recurrent acute or chronic pancreatitis evaluated for the presence of islet autoantibodies. Somewhat surprisingly, at least to me, was the 12% prevalence of these individuals having positive autoantibodies, almost half of whom had multiple positive autoantibodies, consistent with how we now classify type 1 diabetes. Indeed, those with positive autoantibodies had lower beta cell function and higher prevalence of both prediabetes and diabetes, suggesting that these findings, together with those from adults referenced in the paper's discussion, that pancreatitis may trigger islet autoimmunity in a subset of susceptible individuals, and that it may be a risk factor for the development of autoimmune diabetes.
These data are interesting as we now seem to be entering almost another era of really discussing a lot more about the autoimmunity of type 1 diabetes and having discussions around how we may potentially prevent or delay. So understanding what some of those triggers might be, which will obviously be different for different people, certainly adds to that conversation. So this is very good. And I think clinically, we see people who have had chronic pancreatitis and then they start to need insulin, and we just assume that this is all their chronic pancreatitis that has caused this, but maybe we ought to be checking antibodies. So I think I'll start doing things a little differently in clinic. My final pick is a small but mighty study. Dr. Stina Schmedegaard and colleagues from Denmark conducted a placebo-controlled, single-blinded, crossover, randomized trial of women with and without GDM, 20 to 36 weeks, to see how whey protein taken 30 minutes before a meal can impact glucose excursions. There were two parts, a lab part and a home part. For the lab part, they were randomized to take 20 grams of whey or placebo 30 minutes before a 75-gram OGTT. For the home part, participants wore CGM and randomly consumed 0, 15, 20, or 30 grams of whey protein. I should clarify, whey spelled W-H-E-Y, just so people know what we're talking about. So different doses of whey protein 30 minutes before breakfast. There were 12 women with GDM and 12 pregnant women with normal glucose tolerance. Pre-meal whey protein lowered the peak glucose during OGTT by 1 millimole per liter in women with GDM and by 0.7 millimoles per liter in those without GDM compared to placebo. Insulin, GIP, and GLP-1 levels increased rapidly after whey protein. At home, pre-meal whey protein lowered glucose peaks in a dose-dependent fashion with a max of minus 2.0 millimoles per liter in those taking 30 grams of pre-meal whey protein with GDM. This is obviously going to require further validation in a larger study, but it's certainly tantalizing to help women control glucose levels in pregnancy with something that at least sounds fairly straightforward as something that they could add prior to taking their meal.
Another great pick, Alice. My medical school endocrinology professor, the late Francis Sterling, taught that insulin is the hormone that turns food into you, being key not only for carbohydrate storage, but also for protein and fat anabolism. And this article is a terrific reminder of the complex interplay of other nutrients affecting insulin secretion and glucose homeostasis. My final pick is by Dr. Quentin Perrier from Grenoble's Alpes University in France and colleagues from the GRADE network, who undertook a study to evaluate the impact of islet transplantation on diabetes-related complications, death, and cancer incidence in individuals with type 1 diabetes. They examined cohorts of islet alone and islet after kidney transplant recipients who previously participated in 3 clinical trials in France and compared them to propensity match controls with type 1 diabetes who were registered in the French healthcare database and had a median follow-up period over 10 years. The primary outcome was a composite of death, dialysis, amputation, and non-fatal myocardial infarction and stroke, including transient ischemic attack. And as a secondary outcome was cancer. The 61 islet alone and 45 islet after kidney recipients compared to a collective 655 type 1 diabetes controls had significantly lower risk of the primary outcome that was driven by reduced mortality for the islet alone cohort and reduced dialysis for the islet after kidney cohort relative to their respective controls. There was no difference in cancer incidence between the case cohorts and controls, and these findings provide additional evidence of long-term benefit for islet transplantation in diabetes-related complications. And despite the requirement for chronic immunosuppression, no significant increase in the risk of cancer. So, Alice, I don't think we saw an article on islet transplantation in 2 years of diabetes care issues. And now we've had one in each of the last 2 issues from the United States and now France. And as a biased participant in this field, I do feel the availability of an increasing amount of long-term outcomes data is deservedly now bringing attention back to the prospect of cellular therapy as a future treatment for type 1 diabetes.
And it is exciting to see. And actually, this is a nice reminder to our listeners of the symposium that Mike had mentioned in his introduction that he helped to put together that will be looking at different strategies for, I believe you called it immune evasion for the islet cells. So I think this sort of adds to that and certainly encourage people to attend that symposium. Well, this brings us to the end of the June 2025 episode of Diabetes Care on Air. Thank you to Dr. Deborah Wexler and Dr. Justin Echouffo-Tcheugui for sharing their expertise with us.
And a big thank you to you, our listeners, for tuning in. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening.